This work was conducted through the National Drug and Alcohol Research Center, and Emily Aubrey and Lucinda Burns were also involved in this. The aim of the project was to develop a national best practice model for the identification, management, and referral to treatment for women who use substances in pregnancy. We were asked to develop resource for primary care health professionals, and we were asked to focus on alcohol but include all other drugs. The project involved an extensive review of the literature, including effective treatments for pregnant women who use alcohol and other drugs, and involved consultation with stakeholders. There were a range of professionals that were involved, and they had interest or expertise working with women who use substances. And we had representation from every state and territory. We had drug and alcohol clinicians, GPs, midwives, social workers, researchers, and we had representation from sexual health, family planning, justice health, practice nurses. And this consultation group provided extensive input on the services in their state and territory and also current practice. And they provided input into the treatment framework and the resources that we developed. Now, the framework implements a women-centered harm reduction approach, and this quote is from Nancy Poole, who's done a lot of work in Canada on FASD prevention, and I just think it sums up the sort of background for the framework really well. And a women-centered approach demands a paradigm shift away from seeing mothers as unfit, uncaring, and unworthy of support, and towards a more positive perspective on women's capacity for change. It demands that we see and hope and are hopeful about women's strengths, and we support women by removing barriers to treatment and involving them in determining what they need. And also involves a willingness to discuss goals other than abstinence despite the known risks of alcohol and other drug use. And it requires considering all aspects of harm. So just a bit of background about substance use in pregnancy. It can be argued that there are no other group of adults who use substances that are subjected to more stigma than women who use alcohol or other drugs during pregnancy. And it's really well known that stigma is a barrier for women entering treatment. And women with substance use disorders often present very late to treatment, to antenatal care. It's also known, well, I mean, this is obvious, but women who use alcohol and drugs are using them long before they become pregnant, and all the complexity associated with substance use is obviously relevant to their pregnancy and the outcomes. Pregnancy is a time-limited opportunity for women to assess the situation and make change. The evidence also shows that a lot of health professionals are not confident about talking about alcohol and other drug use, or they only target certain individuals to talk about alcohol and other drug use. And women can be quite fearful about disclosing alcohol and other drug use due to fear of child protection involvement. And part of this conflict for the health professionals and women is that, health professionals are obviously mandated reporters, but it's really important that this issue is dealt with open and directly, communicating with women the responsibilities that you have, but also that your role is to help support them and treat them. So ideally, we know that care should be provided free from stigma or judgment, with an aim to minimize harm and with a women-centered, but with the autonomy of the woman respected, providing culturally safe care and using evidence-based treatment. But in reality, there's actually quite limited information on how often or how well health professionals identify pregnant women with problematic alcohol or drug use. Pregnant women are stigmatized, and there's also limited treatment services to support pregnant women. There are some really good services and some very good specialist antenatal clinics, but a lot of these specialist services have an opiate treatment focus, and they do that job really well, but women primarily with primary alcohol problems might not feel comfortable attending those services, and also those services report that they rarely see women with primary alcohol problems. And also a lot of the services are in metropolitan areas. Also, pathways to treatment and care are not clear, and evidence-based treatments, both pharmacological and psychosocial, are limited. So there's room for improvement. Now I've got 50% of pregnancies are unplanned, but it could be 60, so over half of pregnancies are unplanned. And so it's important to talk about minimizing harm in the context and talk about alcohol and other drug use and contraception for a variety of health professionals and health settings in a context of health and a broader discussion of reproductive health. So the proposed framework assesses risk and addresses needs across the continuum of not planning a pregnancy to being pregnant or planning a pregnancy. There has been some work from the U.S. With high-risk women at high risk of an alcohol-exposed pregnancy. The project is called Project Choices, and they get, it's a brief intervention with a motivational interviewing component, and they get women to either decide whether they want to address their alcohol and other drug use or contraception or both, and that's had some good success. So as I said, the framework addresses the issue across a continuum. The dark blue is sort of suggesting that a range of health professionals can talk about this and need to talk about the issue of alcohol and drug use and contraception, and then there are a range of ways to go from there. That's a bit messy, but it's in the resource that you can look into later. And I guess identification and engagement of women is the key to being able to provide effective treatment. So I'll go through briefly some findings from the literature review. I won't go into detail because all the information's in the report if you want specific references or whatever, but I'll just give an overriding view that informed the framework. So with regards to screening and brief intervention, despite limited evidence regarding universal screening, the World Health Organization and all national guidelines recommend to routinely ask all pregnant women about their alcohol and other drug use. And this, if it's normalized and being part of routine care, it can help reduce the stigma. It also removes the subjective nature of health professionals guessing who might be or might not be using alcohol or other drugs. So if it's just standard, the idea is that it will reduce stigma, although there is limited evidence for universal screening. It's important to use validated tools for screening, and there are a range of tools. The tool recommended most commonly in Australia is the Audit C. There's no perfect screening tool, and in the literature review we did find that screening tools haven't been sufficiently investigated in pregnant women in Australia specifically, but they have elsewhere. And with regards to other drug use, the Assist is a screening tool that has been used a little bit in pregnancy, so that could ask about other drug use, or timeline follow back is another method. It's important to assess the level of risk, but then address the individual's needs. It's recommended to provide brief intervention to all pregnant women who are at risk, although there is good evidence for brief intervention in the general population. This is somewhat more limited among pregnant women. A lot of screening and brief intervention referral to treatment approaches use the 5 A's: ask, assess, advise, assist, arrange. It's really important, and maybe obvious to health professionals working in the area, that brief intervention is not enough for women with alcohol and other drug use disorders, but at least it starts the conversation about treatment and support. There have been 6 components of care that have been found to be associated with improved outcomes. Having child care, having early antenatal care, women-only treatment services, and addressing women-focused topics, having mental health services and comprehensive treatment services. With regards to treatment, there is limited research on psychosocial interventions for pregnant women specifically, but there's some evidence for the effectiveness of brief intervention, motivational interviewing, CBT, and contingency management. And there's also limited research on pharmacological treatments for pregnant women. The New South Wales clinical guidelines for the management of substance use during pregnancy, birth, and the postnatal period were released last year. They were an update of the national guidelines for substance use in pregnancy. And although they're New South Wales, so there's some specific New South Wales information, they do provide information on the most recent evidence with regards to psychosocial and pharmacological treatments for pregnant women. So for pharmacological treatments, nicotine replacement therapy is only recommended if psychosocial interventions have failed, and the use of intermittent forms as opposed to continual patches. And that also needs to be considered with regards to whether the harms of NRT outweigh the benefits. Or the benefits outweigh the harms. For opioids, methadone and buprenorphine are found to be safe and effective for women with opioid dependence, and it's not recommended to withdraw women from opioids if they are pregnant. For alcohol, there are no pharmacological treatments that have been shown to be safe and effective, so the acamprosate, disulfiram, or naltrexone used in the general population aren't recommended for pregnant women with alcohol use disorders. You can use benzos in withdrawal, and for cannabis, cocaine, and amphetamines, there's no recommended pharmacological treatments. The thing with treatment, and from the literature that becomes apparent, is that a comprehensive treatment model is required that addresses the individual and social environmental factors associated with alcohol and other drug use, mental health, trauma, violence, and also some of the practical poor housing, poor nutrition, poverty. The Consultation network really just reinforced the findings of the literature review. With regards to identification and there's basically inconsistency in screening across the country, although there's some really good examples of good screening practices, and all states have guidelines about asking about alcohol and other drug use in pregnancy. There's great inconsistency with regards to how women are asked, how the information is recorded, and then how women are followed up. The consultation group said, early and frequent care is antenatal care is required and it improves outcome. Really engaging women is the key. And on this note, the idea that there should be a no wrong door approach, that women need to be assisted wherever they present. And from a few health professionals, they said, women services need to respond to the women where they're at that stage of their journey, as opposed to where the health professionals think they should be. The idea that you need to assess the risk but then address the needs of the individual, addressing practical barriers and issues, the idea that integrated services and co-location of services result in better outcomes, having visiting clinics come in and helping women with transport and childcare. Follow-up of women is important both throughout the pregnancy and also post-pregnancy. And contraception, again, came up as an issue that really needs to be discussed more with this population. So this is the comprehensive treatment model that we put together from literature review, previous work, and consultation. It's not intended for healthcare professionals to do all of it, but it provides aspects that need to be considered or highlights areas that need consideration. And I'll just walk through the different components. So case coordination is a pivotal component to effective care, and this is especially important when services are provided across disciplines, across agencies. And so ideally having a clinical lead that assesses the women's needs and then links them in, coordinating is ideal, and it could be one of a range of professionals. With regards to treatment, again, timely, early engagement is important. With a specialist antenatal clinic, if they're available, or consulting with addiction medicine specialists, providing a range of treatments and services. One of the issues I would like to highlight is, addressing both mental health and family issues, including substance use or alcohol use by the partner, as well, as that can be an area that needs a supportive partner helps, and if the partner is not using, that's a big key for the woman not to use. And then referral and coordination, and this was highlighted as an area that needs a lot of work. And this is really difficult in a climate where services are stretched, funding's being cut. But developing knowledge of what services are available and what services provide, what different services can provide, and the different eligibility criteria, and how to make a referral is an important part. So documenting all that and building relationships to support referrals. Now keep in mind this, we were asked to develop the resource for primary healthcare professionals, so it wasn't supposed to be for people working in drug and alcohol necessarily. It's more broadly health professionals. And interagency meetings where different organizations can get together and sharing information and building networks is really important, particularly when services are stretched and being cut. And there are a list of types of services for referral. And as well as the referral side of things, follow-up, assertive follow-up was also identified as an area where a lot of work is needed. And it's following the woman through to the birth, but then after birth as well. And again, contraception came up as an issue that needed attention, and that sometimes the 6-week assessment where women, that's often too late. So getting contraception advice and provision in earlier, particularly about effective forms of contraception, long-acting reversible contraceptives are underutilized in the Australian population generally, but with women with alcohol and other drug, who use alcohol and other drugs as well. So again, that's the overall sort of framework. Workforce development, including accessible training, is required. It was suggested that online training is a good way to go, but it needs to be ongoing, and making sure people that come into employment in services are given the appropriate information. Specialist antenatal care is limited, so clinicians with those expertise need to mentor and support primary care professionals. The resource that was developed provides some information for individuals on how they can improve their engagement skills, as you know, talking to women and engaging women is really important. So just having a better understanding of alcohol and drug issues as health issues and the complexity involved, refraining from moral judgments on alcohol and other drug use in pregnancy, and acknowledging that alcohol and other drug use occurs in the context of many other factors, family factors, individual mental health factors, domestic violence can also be involved, and also that disclosing information is really difficult, or can be really difficult for some women. Also considering practical barriers and making longer appointment times, coordinating visits with other disciplines so the woman doesn't have to go to a range of professionals. The professionals could come to the woman and potentially provide childcare. For organizations, this idea that referral pathways need to be better documented, clarified, and then locally adapted. Comfortable, safe, and private facilities need to be available. There's very little evaluation of current practice, and also of use of the available guidelines and resources. So there needs to be better evaluation so we know what's currently being done, if any of the tools that have been developed are useful, and how we can improve them. So from this project, the light blue report is a really quite dense report, a review of all the evidence. So if you want references on treatment, screening, brief intervention, it also contains a review of specialist services across the country. The sort of more purple guide is there are already a range of projects and resources that have been developed for women who use alcohol and other drugs. There have been quite a few screening packages put together. Already mentioned today, Sarah mentioned the Women Want to Know project that FAIR put together that has online training for health professionals. There have been Indigenous specific resources developed in Western Australia from the Strong Spirit, Strong Future group. And there have been Indigenous-specific apps developed on how to ask women about alcohol use in pregnancy. So there have been a range of resources that have been developed. And this guide is really wasn't designed to, replicate these. It's more an outline of the components of best practice, and it also has links to all these other resources and tools that are available. It's not, it's extensive, but it doesn't cover everything. But so the purple guide, I think it's about 26, 28 pages, and probably 4 pages are just links to other resources and services that are available. As I said before, the clinical information and the information on pharmacological treatments come from the New South Wales guidelines that were updated last year. On the recommendation of the consultation group, we also put together this 2-page sort of cheat sheet that sort of outlines the framework. With regards to implementation and dissemination, the report and the resource and the cheat sheet are all available on the NDARC website. In addition, the Australian government has just recently funded 13 support services to use the resource, and those services have experience working with pregnant women. And they're from all states except Tasmania, the Northern Territory, and the ACT. And they've been asked to provide feedback on their experiences of using the tool. It's to give contained use of the tool until June 2016, and then their feedback presumably will be used to improve the tool, the guide. With regards to future dissemination and implementation, it was originally hoped that we could develop an online training package with continuing professional development points and provide the support materials and the templates for the local capacity building and service mapping, because that's an area that really needs work. We are hoping to trial the feasibility of the resource in a variety of settings in both regional and metropolitan areas, because obviously there's a huge differential with regards to what services are available in different settings, and then evaluate the uptake of the use of the resource. But it's uncertain what's going on in that space. I'd just like to acknowledge that the funding for this project did come from the Australian government, and there's a list of the consultation network. And as I said, they provided invaluable support on services in their state and territories, but also ideas on current practice and where they thought improvements needed to be made. So you can contact me. That's my email address, and all the resources are on the NDARC website. So thanks.